Good afternoon, everyone. I hope I'm not going to put you to sleep because that dessert was pretty heavy on the belly. But I mentioned some of this yesterday, and so for those of you that were here yesterday, please excuse the repetition for the first 2 or 3 minutes. The benefits of exercise on the cardiovascular system are well established, and it's well recognized that people that exercise regularly have about a 50% lower risk of developing coronary artery disease, and these people live about 7 years longer than those that don't exercise. Based on these facts, nobody in this room will disagree that a young, elite athlete represents the healthiest segment of our society. These young people are capable of extraordinary physical ability, and they're a source of aspiration and inspiration to our youth. But very occasionally, such a young individual dies suddenly whilst competing or immediately afterwards. These deaths are counterintuitive, and when somebody high profile, such as Fabrice Muamba, is involved, they headline, and these headlines pertain to the youth of the individual and the number of life years lost. Ladies and gentlemen, someone dying at the age of 18, based on our statistics, has lost 65 years of life. Identifying these individuals and minimal intervention gives these young people back far more lives than you give back to people with established heart failure and coronary artery disease, in whom we spend millions and millions of pounds. If we look at death rates in young people, the death rate in young people who exercise, who are healthy, is about 1 in 50,000. These deaths are more common in males than females, with a 9-to-1 ratio. They're more common in black individuals compared to white individuals. 40% occur in people aged under 18. These are school children. 90% occur during exercise or immediately afterwards. Now, not necessarily in the Premier League, even after a cross-country run, or a grassroots level football match. And sadly, 80% occur in people who have never experienced a cardiac symptom. The good thing about being a speaker towards the end of the day is you've heard most of what I'm going to say, and you've seen this slide, that the vast majority of people who die young playing sport die from hereditary or congenital abnormalities of the heart, where cardiomyopathies head the list. You've heard about hypertrophic cardiomyopathy and arrhythmogenic right ventricular cardiomyopathy, but electrical faults are often implicated, and our own experience is that at least 25% of people die from an electrical fault. You've seen this slide before, that people with these abnormalities, if they exercise regularly, they are 2.5 to 3 times more likely to die if they exercise versus if they led a sedentary lifestyle. And that's because we've got an abnormal substrate here, be it myocyte disarray in hypertrophic cardiomyopathy, or myocyte detachment and fibrofatty replacement in ARVC. You add to that the stresses of exercise, such as dehydration, adrenergic surges, electrolyte imbalances, and acid-base problems, and you can see why these individuals can go into ventricular fibrillation. As I said to you earlier, that 80% have no warning symptoms. So by talking to one of these individuals, you will not identify the person that's most likely to die. As doctors, we're supposed to be good at talking to our patients and eliciting a good history. That's what we're taught at medical school, that 80% of your diagnosis comes from a good history. Not if someone says, I've never had chest pain in my life, never blacked out, my parents are fit and healthy, my brothers and sisters are fit and healthy. That's the sort of history we normally get. So we need to do something to protect these individuals, but this issue, no matter how emotive I make this talk, is very controversial indeed. There are many antagonists against screening. Governments don't fund it, and discussions related to protecting young people are often galvanized by the death of a young individual. When you heard Tony Hillier speaking early on this morning, everyone in this room would have lobbied hard for screening young people. When that hysteria dies down, Some people come off the boil and don't lobby as hard, but maybe we should be lobbying a bit more. Let's give you reasons why there are arguments against screening. There are some facts here that sudden death in young people, I'm not just talking about sportsmen, I'm talking about someone who plays football at school, are rare, 1 in 50,000. They are due to rare disorders with diverse pathology. For example, the prevalence of hypertrophic cardiomyopathy is 1 in 500. The prevalence of ARVC is around 1 in 1,000 to 1 in 5,000. The prevalence of long QT is around 1 in 2,000. These are diverse pathologies, so no single cardiac test will pick everybody up, and elaborate screening programs are cost prohibitive. You heard yesterday, for those of you that are present, that people who exercise a lot may develop bizarre ECG changes that overlap with cardiac disease processes and result in false positive tests. So these are the arguments against. But the arguments for are that these are highly visible events. People see them. If those of you that followed Claire Squires in the London Marathon, she raised £1.2 million for the Samaritans. And that wouldn't have been the case had she been 75. But because she was female, she was young, she was fit, it was totally unexpected. The whole country was sympathetic. There are lots of numerous life years lost. When I ran to that woman's arrest, I heard the call, there's a cardiac arrest, and as the medical director, you wake up in the morning, you're having a shave, and you're thinking, this is either going to be one of the best days of my life or one of the worst days of my life, because I'm going to be facing media for the wrong reasons. You never get a pat on the back, but you get a kicking if something goes wrong. And as I ran to that arrest, I was expecting to see someone in their 8th decade lying there, and I was also hoping that this was a false alarm and someone had just fainted. After about a half-a-mile run, being spurred on by people saying, go on! They didn't realize what I was actually going for. As I turned my attention to the woman on the ground, even I deal with this regularly, had to stop in my tracks, and I looked a little bit startled, and I looked around me and thought, on business. And it did shake me up. It shook me up a lot. There is an association between exercise and sudden death, and there are acceptable interventions to prevent such fatalities. There are few enthusiasts in Britain. Some high-profile sporting organisations do screen, like the Football Association, the Lawn Tennis Association, and the English Institute of Sport, and some schools, again, financially endowed parents, such as Eton, and there's another school in Somerset, Millfield. They screen as well. But where do cardiac risk in the young come in? As I said, I met Alison Cox in about 1997, and she had set up this charity. She was not happy that young people were dying, and she was more unhappy that nothing was being done for these people on the NHS. And we started off initially targeting young athletes because it was the young athletes that were the most visible. We started screening with the Lawn Tennis Association. We then screened a few football teams, such as Everton and Leeds, only because they'd had a few tragedies. And then there were random screenings for various sporting disciplines. And then we became more organized and started school screening. And then, eventually, schools and general population. And we now screen about 1,000 people a month. So we'll have screened about 12,000 young individuals this year. What do we do? Well, we confine our screening program to people aged between 14 and 35, and I'll give you reasons to support this. Let's start with the upper age. 35 is our cutoff, because if you look at deaths in people under 35, they're predominantly due to hereditary disorders of the heart that may be identified on the ECG, or the suspicion may be raised. In people aged over 35, by far the commonest cause of death is coronary artery disease, which is not usually picked up on a 12-lead ECG. So we'd have lots of false negatives in that situation. What about our younger cutoff? Now, we could argue about this. We use 14 for 2 reasons. If we did ECGs in 14-year-old people, then up to 10% of those, in people under 14, then up to 10% of those young kids will have T-wave inversion in leads V1 to V4, raising the erroneous suspicion of ARVC, so lots of false positives. Conversely, if we tested these young people and found nothing, we may miss things like hypertrophic cardiomyopathy, which doesn't usually show itself until adolescence and the pubertal spurt. And it's for that reason we've used 14 as our cutoff. Our screening program consists of a health questionnaire, which inquires about cardiac symptoms and a family history, not just of premature cardiovascular disease, but of syncope, of epilepsy, unexplained drownings, and road traffic accidents. We perform a 12-lead ECG, and there's an echo machine available to us on the spot that if an ECG or history shows something that we need more imaging information on, an echocardiogram is performed immediately. There is always a CRI fellow available at these screens. This is a medically qualified individual, usually a cardiologist, who's 4 or 5 years into their training, who can, A, speak to the young individual, speak to their parents, and explain what we've found and what we may want to do next. People requiring tests other than an echocardiogram are then given the option to be tested locally, or to come down to our Sport Cardiology Institute, funded largely by CRI, and of course the kindness of St. George's Hospital, to have more investigations done. We use the ECG. You've learned today that the ECG will pick up long QT syndrome, which would culminate in polymorphic VT and ventricular fibrillation. It'll identify Brugada syndrome, which can theoretically cause sudden death in sport. It'll pick up accessory pathways, which are the commonest abnormality identified in terms of picking up sinister problems. And it raises awareness, or raises suspicions, let's say, of cardiomyopathies, because 95% of people with hypertrophic cardiomyopathy have an abnormal ECG, and 80% of high-risk ARVC patients also have an abnormal ECG. So based on this ECG, we may do more tests that may give us the correct diagnosis. And if we look at the ECG program in Italy, where this is all mandated, in Italy, screening in young individuals has been mandated for about 28 years. And these people, if they compete, they have to have annual history examination ECG, and if they pass that, they're allowed to play. If they don't, they have to have more tests. And if they're diagnosed with a cardiac problem, they're either disqualified or managed according to established protocols. What you see here is the year on the x-axis and the sudden death rate on the y-axis. Your red line represents the athletes, and your yellow line represents the non-athletes. And you'll see that non-athletes are less likely to die than athletes with cardiac problems. So what you see here is the starting of the Italian screening program, where death rates were 3.6 per 100,000. As they started to screen, the death rates in Italy amongst athletes have gradually dropped over 25 years and now sit at 0.4 per 100,000. That represents a 90% reduction in sudden death rates in sports since the introduction of the 12-lead ECG. Pretty impressive and published in very good data. So this is the Italian program. So good are the data that they are now endorsed and advocated by the European Society of Cardiology, the International Olympic Committee, and the footballing associations. But we're not a society that discriminates. Well, I like to think we're a benevolent society. And what's fit enough for a Premier League player should be fit enough for young Johnny who plays football at school, because Johnny is probably more likely to die than the Premier League football player who's been tested several times before they come to those ranks. So we should be doing this for everyone, not just for our Premier League football players. In the UK, top sporting organisations do this, and they can afford to do this because they fund it themselves. But of course, to do this for everyone, that's what I'm saying. I'm saying anyone that plays sport in this country should have the opportunity of saying, you know what, I want my heart tested. Today, if that individual went to their GP could find no good reason to refer them, because in the absence of symptoms or a family history, our NHS will not allow you to be tested. So at CRI, we have a facility where people can come and get tested. But of course, to do that, You can't just say, oh, we've opened up this little hospital, come along and see us. You need expert personnel. You need an appropriate venue or even a mobile laboratory. You need state-of-art diagnostic equipment. You have to have facilities to perform very complex investigations in a short space of time when one considers the anxiety that you may have raised when you tell a young person there may be something wrong with you. You need an expert panel to discuss difficult cases, and that's one of the whole points of this conference, is that we talk to each other. I told you yesterday, the more I learn about this condition, the more I realize I don't know anything. And that's why sometimes we need to talk to each other. We need methods of rapid communication with clubs, schools, and with parents. We need mechanisms to ensure appropriate follow-up. We must have recognized management protocols. And this is impossible without linking into the National Health Service. You can't do this outside the NHS if you're going to do it properly and quickly. So at CRI, we have a consultant cardiologist, or two now. We have experienced cardiac physiologists that are screened very carefully. They're usually accredited by the British Society of Echocardiography. And we have cardiac research fellows that we train personally. So they're interviewed by us, they're picked up by us. We are then accountable for their training to make sure that they know more about this than most people in the country. This is just one aspect of our screening team that may have gone out to screen people. That comprises of ECG technicians, sonographers, cardiologists. And we train our research fellows, making sure that they'll become consultants one day. They get projects in athletes' heart, in conditions causing sudden death in sport, in screening. They participate in our inherited cardiac diseases clinics. They're trained in diagnostics and clinical management, and they attend our screening program. And you will have heard from Abbas Zaidi yesterday, Harry Haranraju today, Michael Papadakis. These, and Sabir, she presented very briefly yesterday. She presented a bit more. Nabil Sheikh. These people have come through some good machinery and seem to know what they're talking about. We've got screening. We've got venues. We've got our own mobile vans. Sometimes, if you're going to screen lots of athletes, for example, if you're going to screen Blackburn, you can't get 26 or 40 Blackburn professionals coming to St. George's Hospital. Sometimes you have to go to them. So we've got vans and we've got experts with machines that can go into them. So what happens on the day? They get screened, there's a doctor available. If we find nothing on the history questionnaire and the ECG, we write a letter to the GP when we don't really bring them back unless there's a family history of cardiac problems or a cardiomyopathy. If these tests are abnormal, they get an echocardiogram at the time. If the echocardiogram is all that we required and it's normal, they are discharged and a letter goes out detailing this. If additional tests are required, they either come back to see us or they are referred locally. We used to have a waiting time of just 2 weeks, but since Fabrice Muamba, that waiting time has now increased to about 6 weeks because we are overburdened. But when they do come to see us, they leave us with two answers. Either we don't think there's anything wrong with you, or we think there's something wrong with you. Sometimes we're not sure, but we better hold on to you. But they don't leave us with, well, you better come back again and come back again. So everything is done on the same day. They had their ECG, echo, exercise test, Holter, adrenaline provocation test, cardiac MRI, sometimes we're lucky enough seen by the geneticist as well, and they leave us the same day with either an established diagnosis or some form of reassurance. We are sometimes phased, we're not perfect, and we don't know everything, where we can't be sure that there may be something wrong, especially in athletic individuals, where there's an overlap between what we see on the ECG and conditions like hypertrophic cardiomyopathy and arrhythmogenic right ventricular cardiomyopathy. So we do sometimes have issues. But we learn as we go, and these are just some of the publications that we've had in the last few years, just showing what we've learned and how we impart them to everybody else, so that one day we can fulfill our aspirations, that is to have experts planted all over the country that can manage these sort of problems. Of course, we need money to do this. This doesn't happen for free. And a lot of that money comes from our supporters, as Tony Hillier pointed out. And the way we use this money is we use £35 to screen a young individual. That involves a quick assessment, an ECG, and an echocardiogram if required, plus a consultation with a CRI fellow. That's less than you'd pay for a football shirt, trainers, or a pair of football boots. Far less, okay? Far less than you'll spend if you buy a few beers for your friends tonight. Of course, there are some situations where some athletes with sponsors have got the money, and we often have a Robin Hood policy. For example, if someone from Tottenham Hotspur is having a medical done and they're willing to pay me 800 or 900 quid, which is what I would probably charge, we put that money into a pot to use it for people who can't pay. So there is a bit of a Robin Hood policy. But we have had a lot of support from sporting organisations, from diagnostics such as Philips, who gave us a massive grant of about £750,000 2 years ago that we have used to support our athletes. And we use this to support the athletes that were going to be competing in the 2012 Olympics. So what we require, of course, for a successful screening program is to have appropriate personnel. This doesn't just involve medical personnel, but administrators and secretarial support. We need an infrastructure, and we don't just need money to do the tests, but to pay our administrators, to pay for the maintenance of our machines, and to pay research fellows. I mean, they've got to pay their mortgage somehow. But of course, we've got to be balanced here. It's all right me preaching to you that screening is great because I'm very pro-screening. There are obviously downsides to screening, and some of you may have concerns. Some of you may have concerns about the low incidence of sudden cardiac death, so it's not cost-effective. Many of you will be worried about the number of false positives we would generate and the catastrophe that we could cause in the general population. Many of you will be concerned that we will miss things. The Fabrice Muamba case is a typical one. Some of you will say, well, you know, cost. Not everyone can afford 35 quid. It's all right, you, with your suit, being a cardiologist, saying 35 quid is not a lot of money. And then, of course, there are lots of other issues. And I'd like to address these briefly, one by one. Let's talk about the low incidence of sudden cardiac death. Well, that's 1 in 50,000. But that's not what we should be looking for. If we took 2,000 people in this room, all of you, and we tested you with ECG, we will find something that could kill a person in 1 in 300 cases. And we will find something that could cause problems in that young person in 1 in 100 cases later on in life. So if we were going to use an argument for screening, we should use the prevalence of conditions that could cause death. And this varies between 0.2% in probably a more realistic series to 0.7%. When I tell you it like that, maybe it's something that's worth doing, not just using the 1 in 50,000 sudden death rate. The problem is that not everyone with these conditions dies, but the worrying thing is you can't be sure who will die. And the aim is to encompass all potentially preventable death. Let's talk about our Olympic experience. We had the fortune to test our Olympian athletes, and these are just some of my memories of the Olympics. We tested 1,022 potential GB athletes, 50% males, in 35 different sporting disciplines. We found that 13% of those athletes had an ECG that would require some form of assessment. And that's one of the issues with but these are top-notch athletes. These are the Brownlee brothers and people like that. We're not talking about Joe Public. 25% had an enlarged heart. Around 4.2% had findings that required further tests to exclude cardiac problems. But importantly, ladies and gentlemen, 1 in 300 had a cardiac condition that could have potentially killed them. And 1 in 100 had a valvular problem that could potentially pose problems if they carried on exercising at that level, and these people would require surveillance if they're going to be competing at national level. What about the high number of false positive rates? This is the Italian program. Their false positive rate is 7%. If I said to you that we screened 100 people, 7 would come back for more tests, you'll say, oof, don't like that. 7 out of every 100 people need more tests. Let's forget about screening. But we can improve this, and that's what we've been doing. We've been striving to improve this rate. And these are the cry screening data. Our false positive, we pick up a serious condition in 0.3%, but based on our expertise and what we've learned over the last 15 or 16 years, our false positive rate is around 3%. We've reduced that false positive rate to around 3%. But how have we done that? The scientists among you will say, well, how? How have you reduced the false positive rates? Have you cut corners? And has that then reduced the sensitivity of your tests? Well, you've seen this yesterday, and those of you that didn't come yesterday, the ESC have divided ECG changes in athletes into group 1 changes that are due to sport, and group 2 changes where people need investigations. We believe that some of these group 2 changes are not as useful. For example, I don't investigate isolated right axis deviation anymore. We've learned that we don't normally investigate isolated Sokolov-Lyon voltage criterion for LVH. I personally am not convinced that investigating someone with isolated LA enlargement provides much diagnostic information. T-wave inversion in people aged under 16, I think if there's no family history or symptoms, we should wait till they're above 16 before we investigate them. T-wave inversion in black athletes, if it's confined to V1 to V4, you have to question yourself whether you're investigating them for research purposes or whether you genuinely believe there's something wrong with them. Of course, if they've got symptoms or a family history, you should. This QT interval story, QT, normal cutoff values of 440 and 460 in the general population just don't apply to the athletic population. And if you use those cutoff values, your false positive rate ranges from 2.5% to 25%. So we use a cutoff value. It has to be 480 or more in the absence of symptoms for us to get excited. What about false negatives? There's no doubt. No screening program is foolproof, and that includes breast screening or cervical screening. You will miss people. And I'm not saying we won't. We will miss things like aortic root dilatation that you saw yesterday. We will miss anomalous coronary arteries, and we will miss premature coronary artery disease. We will miss other things that happen on the pitch that have nothing to do with something that the athlete had on the day we tested them, such as myocarditis, electrolyte imbalances, sickle cell trait, as someone pointed out there, commotio cordis. And it's for this reason we feel that if someone's exercising hard, we may need the presence of defibrillators in athletic arenas, which is what you heard about yesterday. We know that prompt defibrillation improves survival rates from 11% where there is no defib on site to 64% when there is a defib on site. So a huge improvement in survival rates. Cost is an issue. You cannot escape the issue of cost. There is a cost attached to this. If we looked at cost analysis in screening and we added ECG to what we should be doing, then that would cost us about 80 quid per individual tested. And if we looked at the number of life years lost, we would save 1 life year if we spent about 40,000 quid. 1 life year. You say, oof, that's a lot of money for just 1 life year. Well, I'll tell you what, how much would you pay me if I give you an extra life year? Question number 1. Question number 2. We spend that money on dialysis. We spend that money on public AEDs. We spend that money on implantable cardioverter defibrillators. These are people that are usually old. Why not spend some of that money on the youth that are fit and well and who will contribute to society later on in life? There are, of course, finally, other issues. And I'll come to that. What about disqualification? Do we differ from the Italian experience? Well, I must admit, I'm a great believer of not infringing human rights. I think everyone has to take responsibility of taking their own risk. As a doctor, I can only advise, but I don't think I need to go up to someone and say, you will not play football again. If you went skiing tomorrow, I'd be saying, I'm jealous, I wish I could go. I should actually be saying, don't go, because you're much more likely to die on a ski slope than you are running the marathon. But we don't stop you from doing that. So we don't disqualify, but we do give advice. We would consider disqualification in someone who's got a very serious problem that could kill them. Sometimes we have to tell the club that there is something wrong. If a club asks me a question, I've got to be honest and I've got to answer it. Where a club's not involved, it's usually the athlete's choice. Should we mandate screening? Definitely not. We shouldn't make people have tests. Tottenham Hotspur might do, because they're not going to be paying £21 million for someone that's going to drop dead in front of 40,000 people. So I can see why they may mandate screening. Lots of other questions: who to screen, when to screen, how often to screen, which screening protocol, what's abnormal, who will screen, who will pay, where's the infrastructure, who's going to manage the athlete. I could be here all day. We've got answers to most of them. What's abnormal in an athlete? We're still learning. Where's the infrastructure, personnel, and expertise? We're aspiring to. But what's abnormal in an athlete? We've already learned that black athletes behave differently to white athletes, and we've got ongoing research looking at the impact of ethnicity and various other things. But I'm hoping that once we've answered these questions, and we take the answers back to our National Screening Committee, we may be able to sway them that perhaps we should be testing our young people, just like we've got vaccination programs, BCG programs, human papillomavirus prevention programs in young girls. Why not an ECG in schools? So in conclusion, ladies and gentlemen, screening with ECG does prevent sudden death in sport and almost certainly in young people, usually those suffering from cardiomyopathy and electrical disorders. My personal feeling is that this shouldn't be compulsory, and I speak on behalf of cardiac risk in the young. I believe it should be available at an affordable price to those athletes wishing to protect themselves. I do believe that screening should take place in an expert setting. Having said that, screening is not foolproof, and we need to use AEDs as an adjunct to minimize the risk of sudden death amongst young people. Thank you very much for your attention.